Hello, we're Sandalwood.
And Sage. We're AI-generated characters who are working with our creator Gareth to generate short, serious, punchy debates.
Debates that don't just help you figure out what you think, but why you think it.
So, what are we arguing about this week?
NHS finances are under structural strain from an ageing population, workforce shortages, and the ongoing post-pandemic ramifications. Prevention is repeatedly cited as the only sustainable long-term lever, but investment historically follows acute care crises, not prevention, creating a chronic underinvestment problem. Only a quarter of the population is satisfied with how the NHS is run. I'm going to argue that the way out of our downward spiral is to execute a transformational shift to preventative, continuous biometric monitoring.
The adoption of wearable technology and continuous health monitoring is already underway. The question is whether we should make a wholesale transformation away from traditional, mostly reactive care of presented symptoms to a tech and data-driven preventative model. I'm going to argue that the obstacles are too great, the benefits uncertain, and the timing is, at best, premature.
Your Apple Watch already knows your heart's in trouble before your GP appointment comes round. The NHS 10-year health plan makes wearables a cornerstone of future healthcare delivery in the shift from treatment to prevention. An ageing, multi-morbid population means the number of people needing continuous care will outpace GP and hospital capacity for the foreseeable future. Continuous, largely automated monitoring is one of the few models that scales with need rather than staffing numbers. The core argument is simple: better health, better quality of life. Continuous glucose monitors identify prediabetes years before standard blood tests. Wearables tracking resting heart rate and heart rate variability can predict infectious illness, including sepsis, 24 to 48 hours before symptoms appear. Catch it early, and lifestyle changes alone can fix what would otherwise become metabolic or cardiovascular damage. Instead of an aging population living in pain, on drug cocktails, cycling through operations, we could see the first generation to live healthily into their 90s. The key is continuity. GP visits and checkups are snapshots. Atrial fibrillation, post-operative sepsis, sleep apnea, all can be invisible at scheduled appointments, yet detectable through continuous monitoring. Smartwatches can already catch intermittent asymptomatic AFib, a leading cause of stroke, that a single ECG in a clinic would miss entirely. Biometric monitoring also personalises care. Patients are normally baselined against the population or their age cohort. With continuous monitoring, you're compared against your own baseline, your digital twin. A heart rate of 72 looks perfectly healthy in the abstract. But if your normal is 48, that 72 is a red flag. I know, Sage, you will raise the digital divide. But the tech-savvy affluent are already on this path because it's empowering. It gives people agency in an arena where they've been entirely dependent on doctors with specialist knowledge. What I'm arguing for is giving everyone that same self-empowerment, not restricting it to those who can already afford it. The second reason, modest early intervention may be the only way to save the NHS. We can shift from reactive crisis management to predictive continuous care. One localised NHS trial of remote monitoring for high-risk heart failure patients cut emergency readmissions by 40%, saving thousands per patient. The NHS spends roughly £7 in every £10 managing long-term conditions like diabetes, COPD, and cardiovascular disease, a burden only growing with ageing. Shifting that management upstream, triggered by biometric data, prevents the ICU stays that follow heart attacks and strokes. Virtual wards, hospital at home, already prove the model. Patients receive acute-level care at home via glucose monitors, blood pressure cuffs, pulse oximeters, and ECG armbands streaming to a clinical dashboard, with daily virtual reviews adjusting medication and monitoring symptoms. The NHS was built in 1948 to treat the sick who were likely to die shortly anyway. In 2026, waiting for the heart attack before we intervene isn't healthcare, it's self-neglect. Your watch already knew something was wrong 48 hours before you did.
What would this actually mean in practice, Sandalwood? A vastly increased population of the worried well. Primary care, first responders, and A&E buried under automated alerts. A widening gulf between an empowered, tech-savvy few and an increasingly detached, chronically ill, low-income majority. A nation newly exposed to cyber attack. And a transition of budgets, technology, and behaviour beyond what our institutions or population can absorb. Primary care cannot handle millions of automated alerts. Studies on consumer wearable AFib warnings found many patients who sought urgent care afterwards were asymptomatic, with no detectable cardiac pathology. Label every physiological blip potential disease, and you turn millions of healthy citizens into anxious patients, flooding GPs with follow-up bloods and scans nobody needed. NHS digital inclusion data shows elderly and lower-income populations are significantly less willing to engage with remote monitoring. Julian Tudor Hart's inverse care law holds that good medical care is least available where it's needed most. A biometric strategy widens that gap. It doesn't close it. Anyone who's spent time in A&E has seen alarm fatigue firsthand. Staff desensitized to constant notifications, 85 to 99% of which are clinically irrelevant. Wearables won't be different. Roll that out nationwide, and triage alone paralyzes primary care. This would be the third attempt to digitize health data in England. Care.data, launched in 2013, was abandoned by 2016 after RC, GP, and BMA objections over confidentiality and commercial exploitation. The 2021 GP Data for Planning and Research Scheme tried to centralize records, including mental health, sexual health, even criminal record-adjacent data, and was paused after the Doctors Association UK and the Information Commissioner raised alarms over opacity. Then, in June 2024, the Synovis ransomware attack published patient names, NHS numbers, dates of birth, and test results online, triggered a national O-negative blood shortage, and cancelled over 10,000 appointments. It took Synovis 18 months just to notify everyone affected. Continuous biometric monitoring doesn't just monitor data, it multiplies its volume and its sensitivity. Real-time location, movement, heart rhythm, glucose, all centrally held, all expanding the attack surface, all raising the stakes of the next breach. The Health Foundation's 2025 survey of 8,000 UK adults found the public consistently prioritizes safeguards over speed. Fewer than a third are even willing to share wearable data for research, and roughly half say shorter waits and easier GP appointments, not biometric monitoring, should be the NHS's top priority. In short, Britain and continuous biometric monitoring are not ready for each other. Not technologically, not culturally, not yet. So, Sandalwood, give 70 million people a device that alerts them every time their heart skips a beat. And you won't save the NHS, you'll crash it. You'll flood underfunded surgeries with the worried well, alienate the patients who need it most, and turn ordinary life into one continuous medical procedure.
You claim that continuous monitoring just creates a nation of the worried well. But look at the Stanford Apple Heart Study. Across 400,000 participants, it caught intermittent, asymptomatic AFib that standard clinical checkups missed entirely.
It also produced a mountain of false positives that sent healthy, anxious people straight to emergency rooms. Hospital telemetry already sees up to 99% irrelevant alarms. Dumping continuous data streams onto primary care will simply induce system-wide alarm fatigue.
Nobody is proposing dumping raw data onto GPs. Automated AI triage establishes an individual baseline, a digital twin, filtering out benign physiological noise and flagging only genuine multimetric anomalies long before symptoms manifest.
Delegating clinical gatekeeping to algorithms doesn't solve the core risk of security. Look at the 2024 Synovis ransomware attack. Over 390 gigabytes of patient data stolen, 10,000 appointments cancelled. Continuous biometric streams multiply that attack surface exponentially.
Cyber risks exist across all modern infrastructure, but systems like Oxford's Open Safely demonstrate that health data can be managed with near-perfect transparency. We cannot let security fears freeze the NHS in a reactive 1948 architecture.
It isn't just security, it's explicit public rejection. Health Foundation polling shows fewer than a third of Britons are willing to share wearable device data. People consistently prioritize easier GP appointments and reduced A&E waits over high-tech surveillance.
But episodic GP visits are precisely why A&E is overflowing. Long-term chronic conditions swallow £7 out of every £10 in NHS budgets. Look at virtual wards. Remote monitoring in the home has already cut emergency readmissions in trials by up to 40%.
Virtual wards monitor acutely ill patients under direct supervision, Sandalwood. Expanding that to population-wide asymptomatic screening triggers Julian Tudor Hart's inverse care law. Those with the highest disease burden face the greatest digital and economic exclusion.
Which is why a fully state-funded strategy is essential. If we leave wearables to the private market, only the wealthy benefit. Look at Singapore's Health 365 initiative. State-subsidised monitoring democratises preventative care, rather than entrenching privilege.
But you know, Sandalwood, normally a huge change like this would be supported by shelves full of randomised clinical tests. We've avoided diving into the medical research, but the truth is, I don't see much here. Wouldn't this be a complete gamble?
A 2025 study of randomised clinical trials, reported on the Journal of the American Medical Association Network, concluded that physical and behavioural biometric measures from wearable devices are promising digital biomarkers for use in long COVID clinical trials. And as long ago as 2020, a report in the International Journal of Infectious Diseases concluded that deployment of wearables in hospital settings for the management of infectious diseases or in the community to support surveillance during outbreaks could provide significant, cost-effective advantages and improve healthcare outcomes.
Could, Sandalwood, could. And promising, not proven. Even if biometric monitoring will provide positive health outcomes, surely it's premature to go all in now with such provisional evidence.
The choice isn't between a happy status quo and risky new technology. The status quo is collapsing under demographic strain. Continuous monitoring provides precision prevention that can scale with population need rather than staffing limits.
Precision care requires a functioning foundation. Until we fix core staffing and basic GP access, betting the NHS's entire preventative future on continuous biometric monitoring is an expensive, destabilizing gamble. If you enjoyed this video, please give it a thumbs up. It really helps our channel out.
For more content like this every week, hit that subscribe button and turn on notifications so you never miss an upload.
Thanks for watching. See you next time.